Yuko. Welcome to the last lecture. So today we're going to cover somatic symptom illnesses and disruptive behavior. So psychosomatic illness is a connection between the mind, better known as the psyche, and the body. There's a thing called hysteria in which a patient can have multiple physical complaints, but there's absolutely no organic basis. Freud said that people can convert unexpressed emotions into physical symptoms, and we do know that is true. One example of that is what's called conversion disorder, where a patient can undergo some sort of overwhelming stress, be perfectly fine, go to bed, wake up the next morning and be completely blind, incapacitated in the fact that they can't walk, or they may be completely deaf. And there was absolutely no medical foundation to it. So somatization is when we transfer those mental experiences and we put them into body symptoms. Oftentimes the body symptoms are going to be vague. So the patient will tell you, I've got a headache, my stomach hurts, my back hurts, but there really isn't anything medically significant that's driving those complaints. So the three central features: the complaints suggest major medical illness but have absolutely no demonstrable organic basis. Psychological factors and conflicts seem important in the initiation, exacerbation, and maintenance of the symptoms. The symptoms or magnified health concerns are not under the client's conscious control. Sometimes it is difficult for clients to be able to discern where the emotional pain is and where the physical pain is. So different types of somatic illnesses: somatic symptom disorder, conversion disorder, pain disorder, and illness anxiety. So the clinical course may begin in adolescence and may not be diagnosed until early adulthood. It can be chronic and recurrent, and oftentimes they doc shop. They go from one physician or a clinic or a hospital to another, and oftentimes they get medications from multiple providers to be able to provide some relief of their symptoms. They oftentimes tend to be pessimistic about the medical establishment. It kind of resembles hypochondriasis, where they feel that no matter what, there's always a medical error that is misdiagnosing them, that the tests aren't accurate, that maybe we ran the test on the wrong patient, and so forth. Malingering is where they do an intentional exaggeration of symptoms so that they can stay hospitalized oftentimes, or that they can stay under the care of a certain physician, or to get certain types of medications. Factitious disorder, one of the examples of that is Munchausen syndrome, where they initiate illness or injury upon themselves to be able to get attention. Another factitious order is the Munchausen's by proxy, where they use a child or a pet to be able to also get that attention. So they differ from somatic illnesses because there's no voluntary control over the symptoms in somaticism. So theories: internalization, alexithymia, and the primary goals are to gain secondary benefits from being ill. It's to relieve their anxiety, their conflict, or their distress. Oftentimes, think about when you were a child, maybe, and you were homesick. My kids, I always went out and bought them ice cream and popsicles, and they got to play the Xbox. So they got a lot of secondary gain from being sick. All right, biological theories say that there may be a difference in regulation in the interpretation of stimuli. So there's different cultural descriptions of this: dot, coral, falling out episodes, sangue dormido, and forget the other one. I can't even say it. All right, so what do we want to do? Symptom management. We want to help to improve the quality of their life. We can give them antidepressants such as SSRIs. We can give them a chronic pain clinic referral, get them involved in education and also in therapy groups. So take a look at their health status, be thorough, do a very, very comprehensive assessment of the patient, get any type of diagnostic labs you may need to get. Look at their history. Find out not only what is going on with them physically, but what's been going on with them emotionally and mentally. All right, look at their general appearance. What's their motor behavior like? Are they walking like they're in pain? Are they walking like there's something wrong with their back? Or are they walking normally and don't appear to be in any type of distress? Also look at their mood and their affect. All right, what's their thought processes like? Are they disorganized? Are they tangential? What's their sensorium like? Are they cognitively impaired? Are they forgetful? Are they disoriented? Or are they alert and oriented? What's their judgment like? And also self-concept, their roles and relationships. Are they employed or unemployed? And their ability to take care of themselves. So what we're going to do then, we're going to formulate nursing diagnoses. We're going to look at the relationship between stress and physical symptoms. Encourage the patient to verbally talk about their feelings. Encourage them to follow a daily routine. Also, help them to be able to express things. Help them to learn new coping skills to be able to deal with their stress and anxiety. And ask them to be able to learn healthy behaviors such as adequate nutrition intake, exercise to work off that stress and possible aggression and depression. So we can also teach them healthy behaviors instead of going out and using drugs or getting intoxicated. Do some large muscle activity to work off some of that anxiety. Help them to learn how to journal and also to be able to maybe focus their energy someplace else, like going on outings with their family, doing something that's enjoyable, not sitting at home focusing on what is distressing them or possibly even making them feel depressed. All right, and then give them the appropriate referrals. All right, hold on while we switch slides. All right, so let's look at disruptive behaviors. All right, these presentations are right out of your book. Whoops, boy, that didn't take long now. So disruptive behaviors are described as persistent behaviors that involve anger, hostility, and aggression towards people and or property. Different types of behavior disorders. All right, and oftentimes with oppositional defiant disorder, mostly in children, they're going to be uncooperative, they're going to be disobedient, they're going to be defiant. They oftentimes have a very limited insight about connecting their behaviors and consequences. All right, it depends upon how severe the disorder is as to what the prognosis is going to be. Intermittent and explosive disorder is equal opportunity, mainly occurring mostly in men who tend to get aggressive with any type of frustration, have a very low frustration threshold, easily irritated and easily angered. They may injure others and themselves, most common in adulthood. All right. And oftentimes there may be a neurotransmitter imbalance in serotonin, okay, and also plasma tryptophan depletion and frontal lobe dysfunction. So what can we do? We can give them medication. We can teach them anger management, and we can also try to teach them relaxation exercises. Tell them to avoid alcohol and other substances because oftentimes they exacerbate. We can put them through classes, help them to lower their risk behaviors, put the child and the parent into some sort of therapy. All right, that's it. You are done with your lecture. So I'll be getting online with you later on Thursday, and we will go through questions. I'll talk to you later. Bye.